Wonderful. So our last presenter is Sinthia Bosnic-Anticevich. Professor Bosnic-Anticevich is a medical researcher and respiratory pharmacist, internationally recognised as an expert in respiratory medicines use. She is founder and head of the Quality Use of Respiratory Medicines Group at the Woolcock Institute of Medical Research and the University of Sydney. Cinthia's research has led to the development of the gold standards in the use of inhalers, impacting on national and international treatment guidelines for asthma, COPD and allergic rhinitis. Her research with different patient populations, healthcare professionals and healthcare settings is key to our understanding of how to optimise the use of respiratory medicines for improved health outcomes. Please welcome Sinthia. Thank you.
Well, it's always a pleasure to be here with pharmacists, practicing pharmacists, who can give me feedback that I can then take back to my group, to researchers, to others, so that we can advance the field with things that matter to you. And while I've got these disclosures up, what I'd like you to do is, if there's any particular topics that you would like covered, if you just want to write it down on a piece of paper, and we'll just collect them quickly, and I'll make sure that we try and cover those things that are of most of interest to you, because there's a lot to cover. But what I'm going to do today is really give you a snapshot of where we're at with asthma management and some of the key things that still aren't done. I'd also like to discuss why some of the key concepts are evolving, and that over time we're going to have to change the way in which we look at some of these concepts in asthma and COPD management. So I'm happy to go into COPD if you would like me to as well. But I'd also like you to think about and tell me, what are the biggest challenges? Well, do you have any challenges with your respiratory patients? And what do you feel are the greatest challenges that you have? And how do you, as a pharmacist, know whether you're doing an optimal job for your asthma and COPD patients? How do you judge whether you could do more or you could do something differently? So I'd like you to think about that, because that really is part of how we can try and change what we're doing. Because I'm not going to sit here and tell you that even though between 60 and 90% of people have poor inhaler technique, you have to train them on inhaler technique. I mean, we've been saying that for 20 years, and if you haven't heard that before, I mean, it's impossible that you haven't heard that before. And talking about inhaler technique and some of the latest metrics, that's a whole talk in itself. But I'm not going to cover that today. I'm happy to answer questions, but it's more than that. So I'd like you to think about those things, because somewhere when I remember, I'm going to ask you about what are your greatest challenges and how do you as a pharmacist know that you're doing an optimal job. So what is asthma management all about? It's all about assessing where the patient's at and a cycle of care that's going to step that patient from one level of treatment to the next. And if you have a look at when we talk about what assessment's about, of course diagnosis, and you might think that's straightforward, but that's not always straightforward, and some people live with asthma for many, many years without a diagnosis, and some people live with an asthma diagnosis and they don't have asthma. So that's not a given. And then there's symptom control, so the symptoms that the person's experiencing. And then there's another feature, which is exacerbations. So everything else falls under things that impact on symptom control, things that symptom control will impact on, or the risk of having exacerbations. Patients can have mild asthma and have severe exacerbations. They can have poorly controlled asthma and never have an exacerbation. They're all so individual, and that's what part of the challenge that we have. But essentially, their symptoms, their risk, and a cycle of care. Now, step-up therapy, that is what it's currently known as. And why is that? And this is from the global initiative for asthma management guidelines. And the reason that I put them up as a starting point, I'm going to show you the Australian ones, which you've seen many times, but the reason that I put them up is because I think they beautifully show what's going on. They say patients, if possible, can start at a lower step. If that doesn't control their disease, they're stepped up. And this very clearly shows that if you're up here, things aren't too good. You've gone all the way to the end and you've stepped up to the highest level. Of course, it's called stepwise because it can be step up or step down, depending on if you're going through a bad period and you can go in the other direction. Our guidelines look like this. In principle, they do the same thing. They're slightly different because the guidelines committees in the different locations of the world haven't had 100% consistency in the data that they think should be involved here. So our guidelines are a little bit different to the global ones, and they're a little bit different to the Swedish ones, and they're a little bit different to the UK ones. But essentially the principle is the same. If patients are stepped up, they're going to a higher level of treatment. So let's just have a quick look at what this means. Let me just see what the next one is. All right, let's go back here. No, we'll go forward, sorry. So what is actually on that diagram that's really, really key for pharmacists, before even looking at, being creative or where we can fit in, but what really stamps us here? And the first is that all patients, they have to be assessed for individual risk. We have to look at relievers, and we have to provide education, written action plans, and we can have a whole discussion about that if you like, because there is a way that we can sort of try and toggle people towards that, even if their GP won't write one or doesn't know how to write one. Non-pharmacological factors and treatment goals and concerns, and quite frankly, we're the ones that are going to see the goals and the concerns, because the concerns are going to reflect in non-adherence sometimes. So we are able to uncover a lot of this, and a lot of this that others can't. And then, of course, they will stamp this everywhere: inhaler technique and adherence. So much. Inhaler technique, yes, but adherence, so much more difficult than what we just, sort of say adherence. So when we look at a patient, we need to feel confident that the diagnosis is correct, which will be something that we do over time. Asthma control, what is their level of asthma symptom control? What is their future risk of having a flare-up, an exacerbation, a severe one? And what are the factors that we can address? Now, Vanessa already mentioned the concept of treatable traits, but when we go into that, I guarantee you have already been doing it. Because we do not sit down with a patient and spend an hour and go through every single facet of what their problem is. If you have a person who has asthma, who has allergic rhinitis, you pick that problem and you deal with that problem. If they've got a problem with adherence, you'll pick that problem. If they've got a problem with avoiding triggers, you'll pick that problem. So we've all been doing treatable traits before they gave it a label. And then finally, flags for referral, which are really, they're tricky and they're not tricky. I mean, we can see a flag for referral, but does the patient see the flag for the referral? So, I'd be interested to hear from you to see what your thoughts are on this, because I think maybe it's a little bit different in your area than what it is in the big wide world. I'm not sure, but you can give me that feedback. Okay. All right. So I wanted to just briefly mention asthma control versus future risk. So probably about 10 years ago, no one ever spoke about future risk. They just said asthma control, asthma symptom control, etc., etc. And that is the symptoms with which the person is living, which can flare up, which can flare, not be present. But this is often referred to asthma symptom control, could be referred to as disease status, it could be referred to as the stability of the person's asthma. Are they experiencing symptoms? And then you have future risk. So this is predicting, is this person at risk of a major asthma event? And that asthma event is usually what we label an exacerbation. So a severe or noticeably worsening of their symptoms that requires a special intervention, oral corticosteroids, more medication, a visit to their doctor, a visit to the emergency department, a hospitalisation. And so every patient will at some stage have a flare-up, which is the red one, say, or exacerbation, which is the red one. But is it a little flare-up, which we don't register as one of these major events, or is there the potential of it being a big flare-up? And so some patients won't have any symptoms and then have a bit of symptoms happening, and that's more a flare-up. Other patients will have symptoms as baseline sort of all the time or on and off, and then on top of that have a flare-up. And they're the kinds of things that we all want to understand, anyone that's got to do with managing people with asthma. Now, how do they advise us to look at whether a person has got good asthma symptom control or good control? Strictly speaking, it's symptom control. It's trying to identify the level of their symptoms and whether they are well controlled. I mean, that sometimes gets a bit confusing because patients will say, I've got good asthma control because I'm taking my medications. So look, that's the nomenclature that's used, and that's whether it's the one that's really the right nomenclature, I question, but that's what we've got to work with. So what do they tell us about how we do this? Okay, so there'll be good control, partial control, and poor control. So I'll just do this as a refresher. I'm sure that you know this because if you're here, you're interested in asthma. So daytime, good control is if patients have daytime symptoms less than 2 days a week, which is pretty extraordinary. I actually think that that's quite a lot for good control, to be honest. And if they use their SABA less than twice a week. I mean, good control should be you don't need to use your SABA. But anyway, we'll leave it at this. No limitations on activity and no symptoms at night. Partial control is one or two of these ones. So symptoms or SABA more than twice a week, more than 2 days a week, limitations of activity and symptoms at night or morning waking, because people's lung function is best in the middle of the afternoon and it's worst in the middle of the night, and that's due to our cortisol levels. So the first sign that a person might be experiencing poor control is they start to wake up at night or wake up early with symptoms or needing their reliever. And poor control is 3 or more of the above. So what is a flare-up or an exacerbation? That is, as I mentioned, if the patient has symptoms that will require them to do any one of these. That's considered an exacerbation. Now, we'll go into what the risk factors are for people who might have an exacerbation. So, looking at our stepwise treatment approach, what are the latest principles? And you probably would have been updated on this a year or so ago, where overall we still believe that most people fall into this group here, which is basically the people with mild asthma. And there's a very small group here for whom SABA alone is recommended. Who are those people? Those are people that only need to use SABA, only have symptoms less than twice a month. Less than twice a month, they have symptoms or need to use their SABA. They don't wake up at night and they have had no flare-ups that have involved oral steroids, emergency hospitalisation. And the reason we have to put that in here, even though it seems a little bit inconsistent with people with mild asthma, is because some people can have mild asthma and have a major exacerbation. So we still have to make sure that we don't include that. Now, on this idea of flare-ups or on this idea of future risk, who are people who are at risk of having an exacerbation in the future? Who can we flag as being a high-risk person? A person who has poor asthma control. A person who's had a flare-up or an exacerbation, one of these things, in the last 12 months. A person with another concurrent chronic lung disease. A person who has been investigated for their poor lung function and their eosinophilic inflammation, and those patients who have some comorbidities that we know are associated with risk of exacerbation. Now, we did a study in 2019 in community pharmacy, and we recruited, we did a snapshot of 400 individuals who came in to buy Saba, and none of them fell into this group. So if you have people that fall into this group, it might be true, but it's based on data from pharmacy, of people who come to buy Saba, it's unlikely. And of these people, 15% were not taking ICS, the ones that were on Saba alone. Now, what's new in this next section? Now, have you heard of the anti-inflammatory reliever? Well, the anti-inflammatory reliever is the new concept that's been around for probably, well, I guess, a couple of years. So what does this mean? Let's look at what we already know. We know that most people with mild asthma should probably be on a low-dose inhaled corticosteroid, not a corticosteroid long-acting beta-agonist, but just a low-dose inhaled corticosteroid, plus a Saba when needed. Well, some research was done in 2 studies, which changed the landscape forever on 2 studies, that actually people in this mild group could actually not take a regular inhaled corticosteroid, but take a combination, a low dose of budesonide as their inhaled corticosteroid and formoterol. So ICS-LABA, this particular combination, it has to have formoterol in it, can't be salmeterol, can't be any other long-acting beta-agonist. But an ICS with formoterol could be used on a PRN basis. So the patient doesn't need to be on a regular ICS, but when they have symptoms, they can take an anti-inflammatory reliever. So they basically were taking steroids when they had symptoms. And you might say that's what most patients do anyway, and I agree, that's what a lot of patients at least do anyway. But now formally, at the milder end, that is now acceptable. And as I mentioned, this can only be with the formoterol combination. It can't be with any other long-acting beta-agonist. Why is that? Because formoterol is the only long-acting beta-agonist that has a fast onset of action. So its onset of action is just as quick as a Saba, within 30 seconds, maximal effect between 2 and 3 minutes, but sustained bronchodilation for 12 hours. So that's what it is, and they're the products that you will see in the pharmacy. They're the low-dose inhaled corticosteroid and formoterol. These other 2 sections basically work on the theory of if people are not well controlled with this medication regimen, then they move up. They move to an ICS-LABA at a low dose, and that increases over time if they're not well controlled. Or they might be on SMART or MART therapy, which is once again a combination with formoterol where it's used as maintenance and it's used as reliever. And there's a newer kit on the block which is not only budesonide formoterol but beclomethasone formoterol. And that also can be used as MART therapy, maintenance and reliever therapy, because it's got the formoterol. And then patients get escalated up to a medium to high dose, and some patients may need additional therapy. So when they get up to here, they might also have a long-acting muscarinic agent, which means that some people who are up here, step 5 for asthma, might have a very similar profile to someone who has COPD. And we are getting new biologics all the time. So what did biologics do? Biologics target particular pathways of inflammation or allergy. So we have anti-IgE, we have the anti-IL-5s or the IL-5 enzyme inhibitors, we have blocking of IL-4, and they are all around high levels of eosinophilic inflammation. We'll get to that in a minute. And we're getting a new one, which is blocking a new cytokine, and it doesn't matter whether you have allergic disease or non-allergic disease, you'll be able to treat them with this new monoclonal antibody, which is coming. This is really just a summary, and I'm actually happy for these slides to be shared. So that was just a summary of all that. Okay, so why is it not so simple? How much time do we have? Okay, how much more do we have? All right, when are we supposed to finish? That's okay. I mean, there's a lot I can talk about, but I just want to know. We're finishing when? At 8:20, 8:30? Okay, all right. Now write down if there's anything in particular, and then in a minute I'm going... Actually, maybe we stop now. So my question to you is, what is your greatest challenge? Does anyone have any challenges? Yes?
Getting people to actually talk to me. Normally they're just like, give me my Ventolin, and they're out the door.
Yeah, that's a big, big problem.
So when you actually do get a conversation with someone and you identify that they should see their GP about getting, corticosteroid, they don't actually, like, how do I know they actually go? Because you don't, yeah. So they're, yeah, and then 19 out of 20 will just walk out the door and with their Ventolin.
What do you think? So I don't know whether everyone heard, but it's you see someone isn't on a preventer or a controller, and you advise them to go and see their doctor. What do you think is the main issue there? Do you have a gut, and do you think it's the same issue for everyone?
I think it's probably common across the board in pharmacies, but the ability to maybe prescribe a preventer in the pharmacy might alleviate some of that problem.
Does anyone else want to comment on that? I mean, that and the other comment that you made about engagement. Patients with asthma, we'll talk about patients with asthma, whether they realise it or not, are very empowered. They absolutely are in control of where they go, what they do, what they read, who they listen to, who they follow up with, whether they take the drug, whether they don't take the drug. Sometimes we assume that they've had the full scope of education or background in their asthma, and they haven't. And they don't respond to a recommendation about medicines just as it is, because they probably don't see that the disease is affecting them to the extent that potentially it is, or that by taking medication they could be better. So, I mean, this is something that you have to try, and I think part of the way of approaching a patient is not going to be the same for everyone, as you know, because you've got patients, and finding that trigger point for that patient, which takes time. Unfortunately, it takes time, and understanding them. And look, there's some tricks, I guess, that you could do to say that once a year you do a review of every single asthma patient and you ask them certain questions. How much does their asthma impact on what they do? Do they find they have to amend anything in their lives as a result of their asthma? Do they sometimes find themselves unexpectedly having symptoms when they didn't expect to? And if they can say yes to any one of those, then that's a trigger for you to be able to have a conversation. But we can't do it every time. Every time a person comes in, we can't keep telling them about inhaler technique. We can't be telling them about adherence. We just can't. It's just not going to work. So if nothing else, if you can say once a year that you're actually going to the pharmacy, this is the week that every single person that comes in with asthma, we're doing like a review. We do it once a year. Or the other way that you could do it is you could look at their date of birth, and if it's, when you're entering stuff into the computer, and if you see it's around, that's like the trigger. Every time it's near someone's birthday, that's the time of year that you ask how you go, like just as a trigger, you know what I mean, as a reminder of what to say. Anyone else want to? Has anyone solved all the problems?
I just want to add to the comment. So we do sleep apnea. Thank you. We do sleep apnea and breathing and read about them. So when the person is having an asthma or condition is bad, they have a very bad breathing at the moment. When they have a breathing difficulty, their anxiousness gets triggered. The parasympathetic nervous system gets triggered. So during that time, they actually, the words you said, they exactly know what to get. If that I get the Ventolin, I will make it better. So they will not go to the second line of listening to the pharmacist. I want to get better, and this will make me better. So it's very hard at that point to convince a customer you need to do an ICS or you need to go for an asthma action plan and things. Like 1 in 4 might listen to you at that moment, but once they get better, and that's it. It's all gone out of there. We should have some system that if someone is coming regularly in a pharmacy or something, we should have an empowerment as a pharmacist to get the feedback to the respective doctors, and the doctors listens to them or takes them as a what is called as a collaboration. Okay, the pharmacist have seen the patient 3 or 4 times, and the patient has to be seen by me. So the clinic or the medical center rings the patient and takes him for the asthma action plan. Yeah. Only if that empowerment is down there, the prescribing and the other things will give a fruitfulness.
Yeah, thank you very much for raising a point. That is an excellent point. As you say, when a person wants to come in and get a SABA, that's what they want to do. They want to come and get it, and they're going to get it. So as you said, that is not the right time to have a discussion around all the other things. That's why if you pick a week in the year and say, or that month, everyone who comes in who has asthma or has been on an asthma medication gets asked, or around, if it's around their date of their birth, you ask them then, not when they've come in specifically for a SABA, because as you said, there is no way that they're going to do anything other than they've come. They want that, they're going to get that, and it's a challenging time. Unfortunately, the research shows, and I'll show you more from these 400 patients, about 70% of patients come in when they've recently had symptoms when they're buying their SABA. So 70% of them, you could say, are not in the right frame of mind to have a conversation outside of here's your SABA. So why is it so more complicated? Because our framework of management is very structured. We have these questions that we're supposed to ask, and it's very, very structured. But in real life, it's not that easy, because every patient is individual, and because the science has provided us with the evidence that there are a lot of different factors that go to a person's chronic inflammatory respiratory disease, and they can be very different for different individuals. So there's all the different triggers, but and we've always known that inflammation is underlying asthma plus COPD, but we now know that the phenotype of that inflammation is different, that the cellular composition of the inflammation in different patients is different. Some people have high eosinophils and low neutrophils. Others might have high neutrophils, which we thought previously was just in COPD, but now we know it's actually also in asthma. And some have high levels of both. So biologically there's differences. Then we also know that some patients have other comorbidities which can impact on their asthma. Then we know that some patients' lung function, exacerbation, symptom burden, and their response to inhaled corticosteroids is different. So we said some people who have minimal symptoms never get an exacerbation. Some people with minimal symptoms get a severe exacerbation. Some people with moderate symptoms get a slowly increasing level of symptoms to their exacerbations. Others have sudden exacerbations. So all of those things are because underlying all of that, there's some variation in the pathophysiologies. And then you have differences in terms of behaviours and attitudes. So in this, 2-minute or 5-minute interaction that you have and the 10-minute interaction that the GP has, they're supposed to work through all of this and then be able to provide the patient with the most optimal management. So, of course, it's a challenge. Now, this is where these treatable traits concepts came in, because as the biology evolved, it was recognised that, there's all these other comorbidities that can trigger an exacerbation. And, in fact, there's different types of inflammation. There's mucus hypersecretion. Some people have it, some people don't. So biologically, all these things were identified as having different, being more or less a factor for different patients. The environmental and behavioural things, and the comorbidities. So, and you've seen these mentioned, so I don't have to go through them again. And so if we look at it this way, nowadays, well, actually, it's not in practice yet, but we're working towards when healthcare professionals in particular, doctors, when they look at the whole patient, they will actually look at certain biological parameters, which will be part of their clinical decision making. They will look at certain other comorbidities that will be part of their clinical decision making, risk factors and behavioural things. And of course, we can absolutely do all of these, but we'll get to that in a minute. And of course, in all of that, it mentions, the patient and the complex thinking, behaviours and lives of patients who then have to take whatever the advice is and put it into practice. Where does it leave us in this? You tell me, where do you think it leaves us? Where does it leave us? Are we getting anywhere or we're not getting anywhere? I don't know. We're sort of getting somewhere, I think. We are getting somewhere. Anyway, we're doing it one patient at a time. That's what we've got to do, one patient at a time. You find some success with someone and then you move on and you try then for the others. And some people you will know you get success quickly, and other people it's a long process. But what do we know about people with asthma? These are patients collected from all these different settings, basically from the community, like a community survey, pharmacy, general practice and respiratory physician. The blue shows what proportion of patients in those surveys had good control, and this is 50%. So pretty much, if you look at anyone in any setting, at least half the people are going to have poor control. And in your pharmacy, only 20% of people that come into the pharmacy for their asthma stuff have got good control. So it might be different in your pharmacy, but in every other pharmacy it's probably there's a lot of people that have got poor control. Adherence, I like to show this because it was made from Australian data, and I think it shows two things. This is from PBS claims data for a 12-month period for people that were prescribed moderate to high doses of asthma medications, so they were probably more to the moderate and above part scale of their severity, and they were prescribed this medication for the first time. And this is 100% up here, this is 60% here, and this is 20% here. And this is looking at the proportion of medicines purchased, or the medicines purchased and what proportion of adherence it was. Now, the yellow line was considered good adherence at 60%, and that was 13% of the Australian population. And then you have these ones here. So this one here is, of course, poor adherence. This one here is non-persistent users, that's what they called them. And then the red one was considered seasonal users. So adherence remains an issue. And we know that it's linked to poor outcomes, you know that. Inhaler technique, I don't know how many times we can say it's bad. Does it matter with different devices? Yes and no. Some devices are more straightforward to use. Yes, they are, but that doesn't mean that patients don't make mistakes. Unfortunately, until the digital inhalers become available, we don't know whether what we see in the pharmacy at that point in time represents what they do at home. It could be that it's a lot better than what they do at home. It could be that it's a lot worse than they do at home. We just don't know. But every time we do these bloomin' research projects, the inhaler technique is bad. But you know it can be fixed. You just got to repeat it and you got to show them. Show them and repeat it. I think you know that. The other thing that we still struggle with is this patient's perception of illness, the perception of their symptoms. And there is Australian data on this, but I like to show this one. This is done from Europe, and I think there's about 4,000 patients in this one. And this here is patient perception of asthma control. The top panel is they think it's good, and the bottom panel is they think it's not good. And then down the bottom are the global definitions, but basically we have controlled, partially controlled, and uncontrolled. Now, on GINA guidelines, so the global guidelines, when we ask the 5 questions that ascertain whether a person has good or bad or partial control, we see here that 40% of patients in this cohort were classified as having uncontrolled or poorly controlled asthma, but they reported that their asthma was well controlled. 40%. That is massive, absolutely massive. And I was just saying at the table before, I don't see patients in the community. I see patients at my research institute that also has a working medical clinic. And occasionally the respiratory or the sleep guys might suggest that a person needs to talk to a pharmacist. And I had this one particular young lady who the doctor couldn't work out why she was still having problems with her asthma, because she was adherent to her medication, and on follow-up I really believe she is adherent with her medication, but she wasn't using very much SABA. And it just didn't make sense. There was something about her reporting and feedback that just didn't make sense. And finally, what I uncovered was that when it came to her SABA, she said, "No, I don't need to use the SABA." Well, how is that possible when you're saying you're waking up at night? What she believed was that if she used her SABA, it meant her asthma was not well controlled. So she withheld her SABA. She didn't take her SABA until she was so bad she really, really needed to take it. Now, I had never come across someone like that before. So for me, that was a real kind of moment where I thought, it's difficult to, there are some things that are just, you can't imagine. Maybe you guys are more insightful than me, and you may have thought that was, you may have picked up on that, but I didn't think that. A young woman who was adherent, having problems and wasn't using SABA, anyway, that was the reason. She was withholding the damn thing. Anyway, we coaxed her out of that, and hopefully the burden is lessened now. Now, the other thing is oral corticosteroids, a massive problem, and I'll show you the data on how big a problem it actually is. We now know that if a patient, this is oral corticosteroid, if a patient takes a cumulative dose of 1 gram, and if you think about how much is in a tablet and how many tablets a person takes in a burst, you will see that a person could get to 1 gram pretty quickly. If they reach a cumulative dose of 1 gram during their lifetime, they are at increased risk of developing diabetes, osteoporosis, and some of the other comorbidities associated with oral corticosteroid use. We've always been taught that it's about long-term chronic use. It's not only about long-term chronic use. Bursts that get the patient to 1 gram cumulative is putting them at risk. Okay, what's happening with our respiratory patients? What do you feel, your sense of how common it is for your asthma patients to have oral corticosteroids ever? What proportion would you don't have to share it, but just think about what proportion of your asthma patients do you think have had oral corticosteroids ever? Now, the first thing is we're trying to avoid exacerbations, those exacerbations that require oral corticosteroids. So if they're having oral corticosteroids, it means that those exacerbations aren't being prevented. The other thing that I think is a problem, that often patients will get 30 tablets of their oral corticosteroid and they won't use them all at once, but they'll have them in their back pocket. So when there's an issue, they know it works. The oral corticosteroids work, and they will take bursts of them and not even tell anyone. Not because they're necessarily hiding it, but just because they're dealing with it in the way that they know works. Now, this study was also done in Australia, and it looked at, now there's a number here of patients, I can't see it right in front of me. 124,000 patients. So this is from a PBS database it must have been PBS database. I'm pretty sure it was PBS database. So this here is all patients who have asthma. The green bit is people who are on low dose. So they're low steps. So they're the sort of milder people. And then the blue people are the ones that are moderate and above. Now, the first thing to note is most of the people who are on inhalers are in the moderate to severe range of inhaler dose, which really doesn't represent where we think asthma is in the community. We think that in Australia, like in many other places, people are shifted up in terms of their treatment, and that really, if they were taking their medication regularly, they probably could be on a lower dose. But of course, I mean, I'm digressing, but it's related. So if a person comes to their doctor and they're on a low dose, and the doctor says, "How have you been?" "I haven't been very well." "Have you been taking your medication?" "Yes, I have." What are you going to do? They're going to increase the dose. So there's a lot of people, most people are on moderate to high doses of inhaled steroids, that's right. Now, if we look at these people, 23% of them were patients who were sort of using their inhalers regularly. But 8% of that group were using oral corticosteroids as well. In the group that were less adherent, 5% of them were on oral steroids at any point in time. Of those people who were on the higher doses and were regular users of their preventer, about 40% had oral corticosteroids. And in the group that was on the higher doses but were not regular users, about 8%. So you can see that a very high proportion of patients, 52% of patients overall, had at some point or other had some oral steroids, and 28% had a cumulative dose of more than 1 gram. So it's nearly a third of them. That's massive. So you need to keep an eye out for that. Okay, I think we should do questions now and just have the last few minutes with things that, because what I was going to show you was a day in the life of the pharmacist, in some pharmacies at least, and this is these 400 patients who were basically profiled as they came in to buy a SABA. That is all they were asked, that was the only criteria, that they were buying a SABA and that they were buying it for themselves. We didn't need an asthma diagnosis, we didn't need anything, just if they asked for a SABA. Incidentally, some of them had not had a diagnosis. Some of them said that they had a diagnosis, but they didn't believe they had the disease. So, I mean, if you want to know the intricacies of the mess that we found, really, you can have a look at this reference, or I can send it through and you can have a look, because there's so much to pick at. There's so many treatable traits to pick at in these individuals who just come in to buy a SABA. But I think maybe better if we answer some questions, or if someone wants to make some comments. I'll just see what we have here.
Thank you. My question is around exercise-induced asthma and where they sit in the treatment pyramid.
They can sit anywhere in the treatment period. About 15% of people will only have exercise-induced asthma, and that is because the trigger is cold, dry air. But so they are a group of their own if they only have exercise-induced asthma. Others will have exercise trigger their asthma, but will have other, will basically have asthma that's not just exercise-induced. So they can sit anywhere. Well, if it's only exercise-induced asthma, they will not be taking regular steroids. They will be taking either on an as-needed basis, or they'll be taking bronchodilator before exercise. The classical exercise-only induced asthma. Whether some of those people have not been diagnosed with asthma that's not exercise-induced, of course we have to question that. If they're having symptoms or struggling or a burden of any kind of respiratory problem outside of exercise, they would have to be reviewed to see whether they actually had asthma that's not just exercise-induced asthma. I'm not sure that we've worked that one out since we've, been looking at all these more complex things.
relation to COPD, probably more so. I know a while back, sort of 10 years or so, the idea was to not use long-term inhaled corticosteroids as part of the treatment. Has that changed now, or?
Yes, sort of, it has changed, yes. So this brings us back to the fact that there are characteristics of asthma, like biological cellular characteristics of asthma, that have now also been found to be present in people with COPD. Now, if you think that there's a lot of different factors that come into the patient's experience of their disease, you can see how they might be different for different individuals. So we know now, or we have more insights that, from a biological perspective, that people who have eosinophilic inflammation, so inflammation in the airways, which is predominated by eosinophils, and they've been diagnosed with COPD based on the other parameters that define COPD, they are good candidates for long-term inhaled corticosteroids, because inhaled corticosteroids primarily work on eosinophilic inflammation. So now we've gone to the next level where we can phenotype these people from from their cellular composition of their disease to say these people are candidates for inhaled corticosteroids. The others, we now know that it's going to be less effective for them. The other real life issue that we have is that many people are upscaled to triple therapy in COPD when they shouldn't be, because they're unwell, because perhaps they haven't had this phenotyping of any of the sort of latest diagnostic tools, that they can keep getting escalated up to triple therapy, whereas they probably are not benefiting from that triple therapy, and they could be on a dual bronchodilator, for example, a LAMA-LABA, and that would be just as effective. But yes, it has changed. And in fact, the way that we seem to be going is that, you know, people are starting to talk about a diagnosis-agnostic disease. So you have chronic inflammatory respiratory disease. It's maybe asthma, it may not be asthma, it may be COPD, it may be something else. So now some people are starting to think, should we not be giving a label of asthma or COPD or something in between, but simply characterising the chronic respiratory disease, chronic obstructive respiratory disease. So it doesn't have to be done by a respiratory specialist. I mean, they're the ones that are taking it up first. I mean, they spend a blooming hour with the patient with asthma. They should be doing it. But there's no reason why it can't be done in primary care. So what are the markers of inflammation? The first one is a blood test. So there is a certain threshold, 300 at 300 for eosinophils, which if a patient has blood eosinophils above that level, they're considered to have eosinophilic inflammation. It's a little bit surrogate, because with the best prognostic feature is high eosinophils in the blood and high eosinophils on a test of exhaled air. And the test is called a pheno test, forced expiratory nitric oxide, because a byproduct of eosinophilic inflammation or activated eosinophils is nitric oxide. And people who have eosinophilic inflammation in the airways have higher levels of nitric oxide. And there's they blow into something and it will tell them the level of. So the most accurate is both the blood and the pheno, but the pheno is obviously less invasive and it's immediate, and it is starting to be used in practice as a marker of eosinophilic inflammation. I mean, a pharmacist could have it in the pharmacy, and someone says, I'm taking, it's even been proposed as a way of, in those people that do have eosinophilic inflammation, looking to see whether a person's been adherent. Biomarkers are sort of coming into it slowly. You have a, by the way, you have a local respiratory expert there, in Dr. Ling Chung. She knows a lot about respiratory disease.
Mine is going to be more on attention seeking from Asthma Australia. So we deal with portable oxygen therapy and things. So a discussion with a severe COPD patient. He's on oxygen therapy, and when we had when I was having a discussion, he was mentioning he got more support when he was very severe COPD. That his smoking cessation got more support from the hospital and from the other health workers. Then he went to the patches, and now he's on oxygen therapy. Whereas when he was on poor COPD and he was on severe COPD, he didn't have much support of smoking cessation. So that's something which, because when you want to go to a portable oxygen, you really need to stop smoking. Only at that point, there's a much of influence is coming and he has to stop, quitting the smoking is happening. It's not happening in the earlier stages where he was in the doctor's place or he has been emergency and he has been in the respiratory specialist. They say at that time you need to stop smoking, but nothing much is happening apart from that one. So it's a cost burden to the Medicare as well, because when he goes to portable oxygen therapy, his BOC, it's very expensive. And PBS is ready to pay for it, but they are not ready to pay in initial stages someone to, a counselor or someone to, look after him when he's a poor or when he's at the severe level itself. Why not?
I mean, one of the issues with the COPD patients is that because their disease is progressive, that they progressively get worse and worse. And so in getting worse and worse, they don't really have periods where they feel significantly better. So they don't actually realise that their lung function and their disease state is progressing. They slowly start to modify their life, and it's only really when it becomes such a burden that they really, that they're unable to function and they get to sort of that palliative stage of COPD that realisation is made. That's a big challenge for COPD. The other issue with COPD, where pharmacists really do have a role, is early diagnosis, because 60% of patients with COPD could have been diagnosed at least 5 years earlier. And the characteristic things are smoking. Well, I guess for pharmacy it would be a flag that they've asked about smoking cessation. Lower respiratory tract infections, so antibiotics for lower respiratory tract infections, and oral corticosteroids for lower respiratory tract infections. They are 3 really critical flags to question whether a person might have COPD. 60% could have been diagnosed at least 5 years earlier. And we know that if they start treatment with long-acting bronchodilators, it can slow the progression of the disease. They're considered disease modifying.
But that factor of the smoking cessation is being said at every level,
Yeah.
but it is not moved unless when the person really goes to the severe COPD that he needs the oxygen therapy. Only
The other thing that I should just, while you're sort of, go ahead.
I was just going to say, Quitline's actually really, really proactive. So you can actually get a referral form online and you can actually self-refer a patient. So whether you're a pharmacist or a doctor or whatever, and then they initiate the conversation with the patient. So it actually works. So to get in a community setting, it's pretty much straightforward for them to get the support if they want it.
The other thing to think about is allergic rhinitis. Most people don't go to see their doctor for allergic rhinitis, and even people with asthma don't speak to their doctor about allergic rhinitis. So really, if a person does have allergic rhinitis, it is important to ask them whether they also have any symptoms in their lungs, because sometimes it gets confused where the symptoms are coming from. So they may not have an asthma diagnosis with it, whereas they really do have asthma, and that's what actually happened. That was what the tragedy was for the thunderstorm asthma when we had the deaths. There were people there who had allergic rhinitis who had not had an asthma diagnosis and basically found themselves in a lot of trouble with asthma. and had never had an asthma diagnosis. So even though, everyone trivialises allergic rhinitis, there will be people out there that also have asthma that haven't had a diagnosis and haven't spoken to a doctor about it. And likewise, if they've got asthma, it's really important to have a conversation about the allergic rhinitis, because the minimum that they should be doing is taking an intranasal corticosteroid. It doesn't matter what they say, the oral antihistamine is not the drug of choice for a person with asthma. It's the inhaled nasal corticosteroid, or that with the inhaled antihistamine. The other thing to look out for, which will hopefully be coming on the market soon, and I have to disclose that I've been doing some consultancy for a company that has digital inhalers, is actual digital inhalers which will have e-connectivity and chips in them, which will be able to show a patient whether they've taken their inhaler correctly, and will be able to show adherence patterns, and some of them will also be able to show some features of lung function. So in theory, they'll actually be able to, as a person's using their inhaler, show if their lung function is starting to go down, which is like a red flag to a pending exacerbation.
Is that a PMDI?
No, it's a dry powder inhaler. The one that I have worked a lot with is dry powder inhaler. There are some on that are add-ons. There's a lot of add-ons that can go on different types of inhalers, and there's companies that specialise in making those add-ons. So the third party will make it so that it's available for all others. But I think there's only one that actually, two that do some measurement of lung capacity. But of course, the issue with the metered dose inhalers is the environmental impact. So the other big conversation piece in the inhaler world is the impact of metered dose inhalers and the gases that are in the inhaler when they manufacture it, in the inhaler when people finish using it because there's still propellant in it. And so the UK has actually, there's a policy there that they want to basically get rid of all MDIs by, it's actually really soon, like something like 2025. So some people are going nuts because they're saying, well, we can't get them to, we've only just got them used to this, what are we going to do? Respiratory physicians are saying, well, not all patients can generate sufficient inspiratory flow for a dry powder inhaler. So, yeah, there's a lot of discussion around that.
And if there's no more questions, I've got a question. Sorry. So it's in regards to your example of the female who didn't perceive or who didn't want to take her SABA because she didn't want to be seen as being not well controlled. And so because I'm working in the health literacy space at the moment, it's that whole word of control, and is there a judgment when we're saying, oh, your asthma's not well controlled? And is there a way around that?
Well, look, this is what people are saying, right? That's what how they're saying it in the guidelines. But I think what you're saying is very important. I mean, under what circumstances would you say your asthma's poorly controlled? What you would say is you seem to be experiencing a high burden of asthma. It's having it appears to be having a high burden on your day-to-day life. I mean, that's the way to say it anyway, because it's much more personalised.
Yeah, and I think that's the whole point of it. It's like, you know, and your questions that you were suggesting to say during a clinic is, you know, what impact is asthma taking on your life at the moment? And I think it's getting that person-centred understanding of how they see their asthma, not necessarily us saying it's well controlled or controlled.
Yeah. And the other thing that we found in this study was that we did ask so you will have heard about the asthma control test, which is a 5-item validated questionnaire which is supposed to realistically and accurately, with the appropriate level of sensitivity, identify whether a person has got good control or poor control. And there's another questionnaire called the Asthma Control Questionnaire. We applied the asthma control test, the ACT, which is 5 questions only, to this group of people that came in to buy the SABA, and what we found was that when we asked something similar later on, they actually gave us different answers. Because I really believe that patients are so used to being asked these questions, and they are being asked when they come into the pharmacy and they absolutely do want a SABA, that they are going to just say, no, I don't, no, thanks. Because that's what they want, and they're not, they can see that there's a barrier coming up and they're just going to smash it. But if you actually ask them in a non-questionnaire kind of way, you will get the truth. And maybe they haven't even thought about it. I mean, what's a person's recall? I'll just show you this data that's come from this digital inhaler because I think it's very interesting. So these are 4 panels that come from it's very rudimentary, it looks very rudimentary. The top one is related to SABA use and the bottom one's related to SABA use. The top one is the time of day, and this is 12 weeks. And this shows you when during the day a person was taking their SABA. And so you can see sometimes it was in the morning, sometimes it was in the afternoon. It wasn't in the middle of the night because it starts at 0, so it starts at midnight, right? This shows you how many doses of SABA they took in that day. And this person, this is level with 2 inhalations a day, okay? So they're taking it, they're taking it a couple of times a day here, but not during the night or early morning, and they're only getting up to two times a day. That's not, we'd like it to be without SABA, but it's not massive use. This here is their peak inspiratory flow, so the quickest time, the rate at which they achieved their maximal inspiratory force is strictly speaking what that is. It shows in a dry powder inhaler when you go, how well do you do it? And the minimum that you would have heard is 30 litres per minute. You've heard 30 litres per minute is the minimum inspiratory flow. Well, this is mapping their inspiratory flow, and 30 is about here. And this is their volume. So another really important characteristic, and this is particularly for people who are using metered dose inhalers, can they inhale long enough? Do they have the lung volume to use a metered dose inhaler properly? So it's not just a matter of coordination, but do they have enough volume to do it, which can be compromised if their disease is not well. So this is looking at volume. Okay, so that's one person. Then this is another person. So they are obviously going for it with their SABA, and anything below here is taking it basically before 6 a.m. Anything above this bottom line is taking it after midnight. So you can see that this person is taking it during the night. You can't disagree with that. This is their peak flow. So their peak inspiratory flow, there's some variability. Sometimes it's tight, sometimes it's more variable. Variability is bad because if you have good lung function, then it's fairly stable. And it's pretty low actually, so it's a bit lower than this person. And this is their volume all over the place. Sometimes it's, and this difference here is like, it's huge. 400, 1,400, 1,000, a litre difference. So this variability is huge, and you can see they're starting to take more doses in a day. And then you have this person. Look at that. Some people live like this. This was a sample of 200 people, and there were, at least 10 to 15 people that looked like this. I mean, what are they going to say to you? Have you? I mean, they could not possibly describe this to you. But what's interesting is this. So if you looked at a 2-week window, both these people, if they ask you, how are you? They'd probably say, I'm okay. Are you using SABA? No, I'm not. A 2-week window. Now, this person doesn't have a 2-week window. But there's lots of combinations of this, I just quickly picked out. But if you were talking to these two people at the same time, at the same point, they look the same. But they're not the same. They're definitely not the same. So at the moment, we don't have these technologies available to us, so we have to find another way to try and get to the fact that there might be different things going on. I think that, that just really shows, we can so easily miss stuff. Anyway.
When those are available, is the idea that it will provide both the patient and practitioner that same information, or will the practitioner get more detail versus the patient?
That's a very important and very interesting question. And they're being developed for the full scope of utility that they can have. I personally think that the first priority should be the patient because they're living with it, and if they understand what this means, they are the ones that can prevent something from happening. They can be the ones that say, oh, I actually see this is happening. What did that action plan, what did that strategy say, what am I supposed to do? So that is obviously a really big piece of that. But the other side of that is that healthcare professionals don't have this data if they don't have it. So you can't just say it's self-management because this should help. It's sort of more a personalised, data-driven approach to clinical decision-making. So yes, it should be used by the healthcare professional, but then there's the balance of, some people are saying, oh, well, I want to know when they start getting bad. Well, not every healthcare professional is going to want to know when their patient's getting bad. That's not going to practically work. So there's a lot of implementation stuff to work out. And it has to be done sort of in a feasible way, otherwise it will just fail. I mean, maybe it should be, and of course pharmacists should be paid for it, maybe it should be about pharmacists being the main person that monitors. They're the ones that give out those digital inhalers. They're the ones that maybe, with the return of medicines, should be picking up those inhalers. Maybe the pharmacist is the one that really takes on that medicine aspect, and when the pharmacist then refers based on that person's individual data, it means something really tangibly. So, watch this space. We will have to wait and see.
Well, weren't they wonderful? Everyone, a round of applause for everybody, for Vanessa and for Sinthia and Jessica. Thank you so much for coming tonight. I've learned a lot, and I hope everybody here is walking away with some new information. Just wanted to let you know that we have some fabulous gifts for our presenters. And if you made a request for the flip chart, we have them here, so we can give you one as you leave. And we'd really like to send out a very short survey to you via your email address, and I think we've got pretty much everybody's email address. We'd love some feedback on the evening. It's been something that we've been wanting to do for a long time for pharmacists, so we're so grateful that you're here and hope that you really enjoyed the evening. So I'll get you to sort of maybe pop up the front before you leave. Any feedback before we finish up? Any questions? No, they're all answered. Well done. Thank you. Thank you so much, everyone. See you next time.